So today we chose some angioedema. We have some older cases. We have an older case. We have one that didn't involve EMS, and then we have some other stuff that we'd like to talk. So I'd like to turn the time over to Dr. Luke Morris. He's our Assistant Medical Director here at St. Al Tampa.
Okay.
Are you on?
I think I'm on. Is this on?
Yeah.
All set up? Okay, good. All right, guys. Thanks everybody for being here. So these are, obviously it's always fun to talk about cases and also to talk about the pre-medical aspects of them, particularly when you know, some of these things, you know, by the time they get to us, it's really important what's been done or what's not been done. So I'm going to just start out the case by talking a little bit about, this is again, like Kelly was saying, this is a case that came in through the door here to the emergency department. This is actually Dr. Nilsson's case, and he was going to try and present it, but he had to work today. So I'm just going to do my best with it. I didn't actually see this patient, but I'll just kind of talk to you about the history, and then we'll do a little interactive sort of thing where I'll let you guys kind of say, you know, what you think or what your thoughts are, and what kind of interventions we could do. So this was a patient that presented with a chief complaint of tongue swelling and allergic reaction. So there wasn't a lot of history that they were able to actually obtain from the patient just because of the fact that she couldn't really speak. So I'll just read you some of the history here off of Dr. Nilsson's report, and then we'll talk about what your thoughts would be if you saw this person in the field. 45-year-old female, history of one-day allergic reaction, which the family thinks was to walnuts. This history is from the family. She'd had some swelling of her lips. She's never had true anaphylaxis or angioedema in the past. Patient reportedly was having a smoothie at 3 o'clock that day. This patient arrived, I think, around 8 o'clock in the evening. It had some fruit, some vegetables, and maybe some mixed nuts in it. Within 30 minutes, she began having severe tongue swelling and difficulty swallowing and breathing. She had some nausea and vomiting and some abdominal pain and cramping. She came to the emergency department immediately, so actually it was probably before 8. She wasn't having any chest pain or wheezing, not complaining of any rash. And further history was not able to be obtained. On arrival, she's tachycardic, heart rate of 150, hypertensive, tachypnic. Her oxygen saturations are okay. What you see is you see a patient that's in severe distress, sitting upright with a swollen tongue in her mouth. Her mouth is held open by the swelling of the tongue. She's drooling a bit. She's breathing through her nose, and she looks pretty anxious. Her lung exam, clear lungs, no wheezes, rales, rhonchi, or stridor. All right, so what's, anybody have thoughts? Like when you see this patient, what's the first thing that you think, or what do you want to kind of do right away?
Concerned about airway compromise.
Okay, good, absolutely. I mean, there's no reason for any delay whatsoever with epinephrine on this patient, right? Airway compromise, your major issue. So, of course, your ABCs, you know, you're looking at the airway, breathing, circulation. You want to see what that epinephrine is going to do. You know, sometimes, I mean, it's with that medication that's going to have the most immediate and sure result, okay? So, obviously, you're thinking, how's it, you know, how am I going to make sure this patient has an airway? So you're thinking that, you're pushing the epinephrine, you're planning for all that process, okay? So, you know, this patient obviously did get epinephrine right away. What's your next thought, or what's your next in this process?
Benadryl.
What's that?
Benadryl.
Some Benadryl, yeah, good. An antihistamine, excellent. Which antihistamine is going to have, you know, relatively not going to work as quickly as your epinephrine, but is also going to be very beneficial. It's going to work.
Well, you had said, so we want to think about anaphylactic shock, but it sounded like she still had a good pressure.
Yeah, this gal is actually hypertensive and tachycardic. But absolutely, in the context of an allergic type of reaction causing angioedema, the other thought is anaphylaxis, right? And so anaphylaxis, you're going to get cardiovascular compromise, shock, all these sort of things, right? And so obviously the epinephrine is a part of that. What other things are just kind of the normal, you talk about ABCs, right, fluid. So ABCs, OMI, that's the way I always say it. Airway, breathing, circulation, oxygen monitors, IV. So 2 large bore IVs, you can start, giving fluids, you've given your you're giving your epinephrine and you're giving your antihistamine. How often do you think about, once you give that first dose of epinephrine, are you good with epinephrine? Or, right, you can give it every 5 minutes, if they need more doses, you can keep giving it.
What route did her first dose of epi go?
IM. Yeah, and that's what I would recommend. IM is a lot of the old literature, you're talking sub-Q, things like that, but just give it IM. And you're going to do that 1 to 1,000 concentration, 0.3 to 0.5, so if you look at it, usually I think the way it's set up and here and for you guys too is it's 0.3 to 0.5 milliliters gives that, of that 1 to 1,000 is going to give you your appropriate dose. So yeah, you're thinking repeated doses of epinephrine and IV, the fluids, the antihistamine. Another thing you can do is you can do Solumedrol, IV steroids. I know you guys don't have those on your protocol. That's fine. Those aren't immediate acting. Those are one thing that we're going to give once they get here. So, and then obviously the airway. So I'm going to just kind of talk a little bit about what happened with this patient, kind of go through their department course, and we'll ask some questions and talk about some things in between. If you guys have questions, stop me at any time, and feel free to ask those. So the patient was seen, she was in critical condition on arrival, met by the doc, the staff, seen right away. 2 large bore IVs, 2 liters of saline, 0.3 of IM epinephrine, 40 milligrams of famotidine, which is another choice, an H2 or another sort of an histamine blocker, because this is, in this case we're thinking allergic reaction, and so the Benadryl is a traditional a traditional like a histamine blocker, and then medicines like Pepcid or ranitidine, some of these other medications, famotidine, they can also be beneficial. So I don't know that those are necessarily things that you guys have, that you guys carry, and it's not that critical right away. So famotidine, Benadryl, 50 of IV Benadryl, 125 of Solumedrol. RT came to bedside, was called to administer a Duaneb. Not a bad idea, especially if there's any airway issue. A bronchodilator is going to be beneficial, and to kind of open things up. Another thought too is racemic epi can also be beneficial, but if you're giving it IM, usually that's good enough. Sometimes we would. So thing that was great, so here too, anesthesia was paged right away for crash cart, difficult airway, and intubating bronchoscope. That had to come from the, okay, so intubating bronchoscope. These are the things, these are nightmare airways. Nobody's gonna joke with that. Obviously, you bring one of these to us, if we are able, we're gonna wanna get anesthesia there, even though we work in a more controlled environment than you guys do. It's still one of those deals that you want everybody, you want all your best resources available because it is a difficult airway. So gyroscope was brought to the room, pharmacy was called and present, so you can see a lot of resources got involved here.
So the other one we had there was happened to have a surgeon there, so he was preparing for a surgical airway in case we needed it.
Yeah, absolutely, and there was actually a surgeon in the department at the time, and so they grabbed him to prep for an open cricothyrotomy. Okay, so over the first few minutes, the emergency department course, we're talking just like within a very short period, she rapidly worsened despite all of the medical therapy. I consented the patient with a verbal nod of the head for an awake intubation. Why would you want to do an awake intubation in a patient like this? What are you thinking if you had to intubate a patient like this? What are your thoughts? What kind of things would you want to do?
Well, so in the awake intubation for you guys, are you going to do some lido?
We're going to do lido, yeah. We're going to try and do some topical stuff. You can do some neosynephrine, things like that. When you talk about awake intubation, what does that mean? Does that mean just, like the patient's awake and you're just shoving things in there? Or
there's no paralytics, right?
No paralytic, exactly.
Still sedated.
Yeah, you still.
Knock out our respiratory ability.
Exactly, and that's the thing is in a patient like this that's this compromised, that there's a question about your ability to ventilate that patient, to bag valve mask ventilate a patient like this. You want to consider the fact, if I paralyze this person, I've knocked out all of their efforts. I mean, they're able to do something. We have this natural fight for life that even if, our tongue's swollen, we can't, I mean, we're gonna get something there, So you want to maintain that for them, but you also want to be able to try and facilitate some of your practice. RSI is awesome in the fact that you can paralyze someone, that you don't have to worry about vocal cord spasms, that they don't buck and move, and it just optimizes your ability to intubate. But this is not a case where you want to paralyze somebody. Just because of the fact that it's going to be a problematic airway. You know that, so you want to at least kind of allow them to maintain some of those things. I don't know if any of you have ever had the situation where you had a really bad airway that you paralyzed. I've had it, and you can't get them intubated. When that paralysis finally wears off, that sucks, it's almost kind of a relief, you know what I mean? Even though you still don't have an airway, it's like at least they can do something on their own, and you're still working at the process. But anyway, so that's a thought. We'll talk a little bit more about this. So anyways, so the preparing for awake intubation, and then I'm just going to describe kind of what they did here, which is the benefit of having an anesthesiologist resources, the ideal situation. And then as we go through a lecture here, we'll talk about if you guys ran into a situation where you're kind of out of options, and it was something you had to do in the field, some options that would be available. So, so they prepared for 7.0 nasoendotracheal intubation with a fiber optic bronchoscope. Patient was given nebulized 4% lidocaine, administered by RT, and ketamine was asked for at bedside to provide dissociative sedation without respiratory depression, so the patient could continue to breathe on her own, help maintain her oxygen saturations while we attempted what was to be a very difficult intubation. I was not able to approach the patient from an oral approach. I attempted 2 passes with a nasal fiber optic bronchoscope through the right nair and was unable to see the cords. I did pass it into the esophagus, however, there was significant edema in the oropharynx. I was not able to pass the tube into any target. Then stepped aside and asked the anesthesiologist, who at that point had arrived to the bedside, to attempt. The anesthesiologist attempted. He required multiple looks with the bronchoscope and initially placed it in the esophagus as well. This was quickly discovered and removed. Another attempt was made. The patient required a second dose of ketamine during this to provide continued sedation. She received 200 milligrams first dose, 150 second. Morgan was able to pass an endotracheal tube through the right nair into the upper trachea on his second approach. He had good color change, bilateral breath sounds, more apparent on the left than the right, missed in the tube, was secured, chest x-ray showed good placement. He had complications of bleeding from the right nair. Much of this was able to be aspirated orally, nasally through the endotracheal tube was done, placed on a propofol drip, and then paralyzed after the airway was secured. So in talking with Dr. Nilsson on this, he said that actually, so the surgeon was available, he had the neck prepped, he was ready to perform a cricothyrotomy, an emergent cricothyrotomy on this patient. And I guess it was, she was so edematous in her oropharynx, or so much laryngeal edema and everything else, that they couldn't see cords, they couldn't see anything, even through the fiber optic scope. I mean, at that point it had progressed, and it progressed rapidly. So what they did, and what do you do if that's, what's an option that you might have if that was the case, you can't see anything?
Bougie move, I feel.
Great, so you've got a bougie. What can help with a bougie? Say, okay, and this is totally hypothetical because it's going to be hard to say. Say you're able to barely visualize that area, but most of the swelling is back in the laryngeal area, so you can't see cords and it's all edematous back there, but you can get a laryngoscope in and you can kind of see down there a little bit, and you have a bougie. What's another option?
Back up right pressure?
Yeah, sort of. So you can have somebody push on the chest. You can have your partner push on the chest, and if you see some bubbling, push it right where it's bubbling, you know, because that's essentially what they had to do on this patient. The anesthesiologist was looking with the bronchoscope, standing up on the bed, patient sitting up, and that's another thing too with these awake endotracheal with people like this. You want to kind of try and keep them sitting up if you can, if you have to. I mean, if they're crashing and it's easier to position them that way, that's fine. So anyway, they were able to just see, he was able just to see a few little bubbles, and he was able to push it in there. So unfortunately, they got it done. But again, kind of a case that was a little difficult. I guess there's a PEDS case that I haven't looked at that we're going to look at a little bit later. I'm going to talk about one. Do you want to look at that one now? Or I'm going to talk about one other case that I had from a while back, and I can't remember. I know one of the Canyon crews was involved in it, and I'll just kind of from memory, we'll talk about kind of that one and how it was different from this one because it was a pre-hospital case. We'll go through a little lecture and then we'll look at this other case on a kid. So does anybody, this was a case that went to West Valley. It was a gentleman that Homedale BLS first responded to, and then I don't know which Canyon crew goes out there to Homedale, or if it's not a regular, one. But this was a guy that was a angioedema code, actually. So so this case.
How recent was that?
This was in the last 6 months to a year, maybe like 6 months ago.
All right.
You know which one? Or? Okay.
Yeah, he didn't code until he was forced to lay back.
Yeah. It wasn't called as a code. It wasn't called as a code.
I guess what I would add to that, the little takeaway from that is if you force a patient to do something that's uncomfortable for them, that primal thing you were talking about, they're fighting against you for a reason. So.
Yeah, absolutely. So this case, situation was basically, and we'll kind of talk through it and kind of get some of you guys' thoughts and involvement too. This was a gentleman, he was I think he was 50, he was in his 50s, so middle-aged guy, a little bit overweight. Of course, he's got, I think he had facial hair and, oh.
You're describing me. What happened?
All right, so anyway, I guess he has.
We were doing props, but hey, that's all right.
History of gout. Apparently, he'd seen his primary doctor and started a regimen of some gout medications a couple of days earlier with some anti-inflammatories, etc. So he actually was like maybe the previous day. So that night he started, like over the course of the night, he was having a few symptoms. He started to develop a little bit of angioedema. And so I don't know, I think he lived alone, but over the course of the night he was gradually getting worse. Finally he calls him, or a family member calls and says, "How are you doing, man?" And he's like, "Oh, I'm not doing very good. I've got this swelling." I don't know if he'd looked at himself or knew how bad he was. So they called EMS. Homedale BLS basic response first. They arrive, they find a guy, okay, and we'll just start with this, this is how it presents. You come into the home or whatever, and you find a guy with basically stumbling around, confused, a little bit cyanotic appearing. He's like, wobbling, just out of it, can't speak to you. And the way it was described to me before they brought him in is that his tongue was the size of his foot. Right, so that's what you see when you walk in, right? Okay, so just starting over again. So what do you think? What's your first response? What kind of things do you want to start with this guy? So of course, Homedale Basic. I think the first thing they're doing is calling to get the the other support and crews going, but. So this guy was given a dose of iron.
Yeah, he's happy, and we need to be worried about maybe going crack on him. Right?
Yeah, you got to think about all that stuff very early on. So anyway, he gets a dose of. This is the way I know the case or whatever. You may have heard different things, but so anyway, so apparently they show up. The guy's like this, so they give him a dose of IM-Epi. They try to get monitors on him and get things started. As soon as I think he gets the dose of IM-Epi, they lay him back and he becomes unresponsive. Check a pulse. The guy's unresponsive. He's pulseless. I can't remember exactly what his initial rhythm was. It was not a shockable rhythm. So I'm assuming it was probably a PA of some sort. The guy had obviously been struggling for a while. the epinephrine had nothing to do with the fact that he went into arrest. That was the right thing to do. So anyway, he eventually gets on monitors, CPR is initiated, the advanced crew arrives, attempts were made at intubating the guy while epinephrine and your normal ACLS protocols were being followed. Obviously, it was hard to see, couldn't get any sort of an airway. Eventually, they were able to put an LMA in and provide what was felt like a little bit of ventilation, which was okay. I mean, obviously, you're in a bad situation. You're just trying to do that and trying to get the guy transported, and then transport was initiated and ACLS protocols were continued. What's the issue with, like, say in this case, what would be the issue with an LMA?
I can't believe it even fit in there.
Yeah, I mean, yeah, and I'm sure it was like a lot of effort and just you can't see anything, but the advantage is you don't have to see, you can just push it in. The disadvantage is you don't know what's going on back there. You don't know what the airway, the edema is like. You don't know if it's going to ventilate anything. I mean, it's not a secured airway. It's not it's not going to protect against those things. So it's something though. I mean, after those attempts. So anyway, so the guy, we received a call, that they were bringing in a code. Guy had angioedema. I went ahead and called surgery and called anesthesia because it was 8 o'clock in the morning. So those resources were available. However, because of where it was and everything, I think by the time it got there, the guy had been down for 30 minutes or so, and so we continued those. We were ready. I had the surgeon there with the thought, like, let's crack the guy right now. Anesthesia's there if you want to take a look. But then the thought was, well, the guy seems pretty dead, because he's already, been going through this. We haven't had a perfusing rhythm for a long time. Anyway, so we kept throwing meds in. Another attempt was made at intubation. It was felt that the LMA was ventilating the patient at that point per anesthesia, and then we got a pulse back. And so then the surgeon jumps in, cracks the guy, and he ended up going to the OR for a tracheostomy, and he was on life support for a couple of days, but didn't do that well.
Do you have any idea what the timeline was between when he went down and when the LMA was actually placed? Because Homedale's BLS, so they're not throwing in LMAs, they're not running maybe an OPA, they're not getting any right stuff, so I'm guessing he was down for a long time before that ever happened.
Yeah, I don't know the time frame, and unfortunately I didn't have the case to kind of pull and review all those things, but I would assume it was a little while. So
Kind of unfortunate, because I mean,
it's a tough case. Yeah.
So did this,
Yeah.
if I understand you correctly, then this gentleman showed up in arrest?
Oh yeah, he
The one I'm thinking of showed up talking, and that was a different, but
Oh yeah.
almost same scenario, but didn't arrest until
Yeah.
heading to the OR, so.
No, this guy arrested almost immediately after EMS arrived. I mean, he had clearly waited way too long and lived in Homedale. But no, I'm just no, and I think everybody did their. I mean, it's a difficult situation. Everybody did their best, so.
How were the landmarks on his cric?
No kidding.
On his trach, was he completely swollen up, or was he just kind of?
His anterior neck was not that swollen. I mean, he was a bigger guy, had a little bit of a bigger neck. I mean, so it's not going to be, like a real skinny, easy landmarks, easy like open trach sort of situation, or the easiest to find is cricothyroid membrane, things like that. But so yeah. Good thought. Those are things. Obviously, that's the first thing. One of those first things too, when you're looking at that guy, is you're thinking, like, geez, if I had to look at landmarks and try and figure out where I need to go here, where do I want to be? So, so let's just run through this lecture a little bit, and then we'll talk about a few of these other things. Oh shoot.
You're good. Okay. So you should be down there at the bottom where it says P.
Yeah. You want to just, oh, okay.
You have the mouse
Okay, go.
down there at the bottom.
If I can find the mouse. There we go. right.
Yeah.
Where you at?
Right next to that.
Okay. All right, so just kind of a review of some of the things that we've talked about, and then we'll add a few other elements to it. Talk about different kinds of angioedema as well. So, angioedema basically is non-demarcated swelling of the dermal and submucosal layers. Normally when we think about it, we think of that angioedema of the oropharynx, the mouth, the face, right? Like what you're seeing here. It also happens peripherally. You've all seen the person that's having the allergic reaction. They've got the hives, they're all, welted up. They've got the urticaria, and they've got like swollen hands and feet and stuff like that. So it happens throughout those regions. So there's different types and causes of angioedema. There's your standard classical allergic angioedema, which is what we mostly think of. This is an immune mediated process. It has to do with IgE and mast cells and that whole issue. Basically, to kind of simplify it and think about it, it's basically the immune system overdoing its job. It's just over responding, and some folks are just wired that way where it just does too much, and so there's some sort of an allergen, whether it's a food, an environmental exposure, whatever it is, bee sting, things like that, that's causing the body to respond, the immune system to respond this way. Often, but not always, associated with urticaria. Sometimes associated with anaphylaxis and shock and everything else. The case that came here, she didn't have any of the skin. She didn't have any urticaria associated with it, so it's not always the case. So if you see someone that's got angioedema, but they have no obvious inciting factor, which a lot of times they don't, and they don't have a rash, things like that, don't assume that it's not allergic. I think basically you always assume that it's allergic until you know otherwise, right? So treat it like it's allergic is the way that I would approach this, because there are things that you can do for that as opposed to some of these other things where you can't do as much. So that's the first type of angioedema that we're gonna discuss. The other type is ACE-induced or angiotensin converting enzyme medications, which are used for blood pressure. These are your prils, lisinopril, enalapril. They're first-line medications for hypertension. They're widely prescribed, used extensively. We saw a lot of this where I did my residency training. A lot of it was because we had a big African American population, and it seems for whatever reason, demographically, they seem to be more affected by this. It can happen, usually it's going to happen within the first couple of weeks of starting the medication, but it can happen after you've been on the medication for a long time. So just because so medication list is really important, understanding what medications they're on, because we're going to want to know that. You guys need to know that. And I think why would you need to know if they are on an ACE medication? What kind of thing, why does that change what you're going to do or what you're going to think about? Anybody have any thoughts?
Well, I'm spitballing here, but it might change the treatment course.
Okay, yeah, it might. Like I said before, always assume it's allergic and just treat it as allergic. But if they're on an ACE, have in the back of your mind, a lot of this stuff's not going to work. Have in the back of your mind that there's a possibility that none of this stuff is going to work. Because that's the thing with these ACE-induced folks is if they're bad, you're either just going to watch them and hope that it gets better, or you're going to secure their airway early, because you're going to assume that the medicines aren't going to work as well.
So there's no antidote for this?
There's not. The antidote is stop taking the medicine. Yeah. Which is too late, right? And don't ever take it again. But so anyway, that's that process. The next one that we're going to touch on a little bit, which again is something that you're not going to really be able to do. With the ACE and the hereditary angioedema, you're going to do all of your things that you would do for allergic. Just assume that it is, and then just airway management. And of course, with allergic, you're going to consider anaphylaxis and the fluids and everything else that goes along with that, pressors and things like that. So the hereditary angioedema, this is a process that is also immune mediated, but it's a little different. It's actually a result of a deficiency in one of the complements within that cascade. So obviously we're not going to get into all the details of that, but what you need to know about this one is that usually people have like this repeated pattern, oftentimes with peripheral edema, sometimes facial angioedema certainly can happen, can cause airway compromise. A lot of times it's very often associated with abdominal cramping, pain, things like that. Most of these people know that they have this. Usually it's going to be diagnosed between 5 and 15 years old, not always. We do have a couple of people in this community that have this condition, okay? They usually are aware of themselves enough that they'll get here early, and so you guys probably won't be called on them. But do keep in mind that there are going to be cases where you may be called on these people because it gets late and or progresses real rapidly. Here at the hospital, we have a medication. We have some medications. They're highly specific medications that are quite expensive that address these issues that we give. And we give them early. So most of the time they'll know where they need to go, where the meds are, and they'll come in.
Do they still have a specific trigger, or is this just...
No, well, not really. However, people with underlying disease like this can have traditional triggers and allergic reactions type of components to it. And especially early on, they usually will respond to epinephrine and other medications that are used to treat an allergic type reaction. It is still immune modulating. The problem is that they need something more than that, and that's where these other medications that the pharmacy mixes up and we get special ordered and everything else come into play here.
Are they typically on any kind of a chronic regimen or anything?
Some of them are, but not usually. I mean, some of them are just kind of like some normal allergic sort of things. They used to do, you know, there's sometimes FFP is given to them, but now they say don't do that because it makes some of them worse, and so there's different details. For the most part, I mean, for you guys, it's just kind of trying to get them here and maintain their airway and do what you would normally do.
Would you expect that they would be prescribed an anakit of some sort, or?
No, because the anakits are so, it'd be great if they could.
Diagnosed at 5 to 15, but is that an expectation that age will wipe this out, or no?
No, I mean,
you're seeing these people in their 40s.
Yeah, that's when we actually usually see them. So, and there's not, I mean, this is not that common, but there are a few that we have here in this area. And then the other cause is idiopathic, everybody's favorite. Who knows why it happens? I mean, and a lot of times we just assume it's some sort of an allergen. People get allergy tested and they never find out, and that's fine. Just try and avoid things. Okay, so back into treatment. We've talked about most of this already. ABC, OMI, you know, with airway management being kind of the big thing there. The epinephrine. If they have angioedema, especially if it's compromising at all, or if it's impending compromise, there's usually no reason not to give them some epi. And there's your peds dosing. You don't want to exceed 0.3 on your peds. Most of the time, I think don't you guys just have prepackaged syringes, or you guys mix it up yourself?
Just depends.
Depends. Okay. Your antihistamine, your steroid, and then other things that we talked about, crystalloid, especially if you're concerned about anaphylaxis or developing anaphylaxis, but really it should be fine in everybody. Neb, racemic epi, the H2 blocker, like the Pepsid and those other meds. Okay, so when we talk about the airway management, which is what we'll talk about for pretty much most of the rest of this, you know, you want to assess early and often, you know, the kind of things that you're thinking about. What's swollen? Is it just part of their lip on one side? Is it the whole lip all the way around? Is their tongue swollen at all? Is there something like where look with a tongue blade, can you see their posterior oropharynx? Is the uvula swollen? You know, what do things look like back there? How is their talking? Are they able to swallow? Are they breathing okay? Are they drooling? I mean, you know the things that are ominous You know, if the tongue is very swollen, if they're drooling, if they can't speak, if they can't handle secretions, those are things that you want to be real concerned about and secure that airway if necessary. So when you call ahead to the receiving facility, a couple of things that we've kind of talked about that are important to know is kind of really what things look like, where they're at as far as their airway condition. If they're on an ACE inhibitor, if you're able to obtain that. If it's a clear, you know, like, hey, this person got bit by or stung by a bee and then this started, they're allergic to bees, or if there's a clear inciting, you know, history of angioedema, allergic reaction, we know those things. If they happen to be one of these people that have the hereditary angioedema, you know, because then we can call pharmacy and say, hey, get this ready for us. So those things are important. And then we're going to talk, you know, in this situation, if you need to proceed to endotracheal intubation, what kind of things, and then surgical airways. Okay, so we kind of just went over this. Another thing is to find out, like, when did it start? How quickly is it progressing? That sometimes can be a predictor. And just anticipate that it is going to get worse. So here, you know, it's just part of the lip, but you're watching it. This is all the lips. You can see here, this is just part of the tongue. You've probably seen that before. And sometimes, you know, a lot of these will, like, you know, part of the lip, part of the tongue, those aren't going to progress to needing an airway. They're going to do okay a lot of the time. They could progress to that. But you never know, because this is where you might see it and it might progress. This is where you might see it, medical therapy might help. If this is where it is when you show up, that's bad news, right? And so... So if you have to do an awake endotracheal intubation, you want to oxygenate them. Nasal trumpets are still great, you know, for that process of oxygenating. And obviously, if they become unresponsive and you have to bag, you know, those are going to help out. It depends on how much they're going to tolerate that as well. You know, you can try some of the topicals if you have to. And then we talk about the awake endotracheal intubation. We're talking about sedation without paralytic, which we talked about before. Probably the best things that you guys have to use are going to be your Versed, fentanyl. It's always good to use some sort of a combination of those, I think, if you have to do that. I don't know, we don't carry ketamine, do we?
Only my party pack.
Okay. Okay, so ketamine can cause bronchorrhea and like more secretions and stuff, but we still like to use it because it does give a good element of dissociated amnesia. They can still maintain the respiratory drive, but they're out of it and they don't feel the pain. It's a single drug, you know, so sometimes that's helpful. And then you know, think about your techniques. If you have a long transport and you know, and you're there early and you can see an airway. I mean, a lot of it's clinical judgment and it's tough, you know what I mean? You could always consider, you know, an early awake endotracheal, or even if they're not bad and it's obvious and easy, you know, you could think about RSI on a patient like this. But, you know, again, those are the concerns, is if you cannot ventilate these people, you're going to run into a big problem. And if you're assuming that it's going to progress quickly. Now, if you're close enough where you can get them somewhere quickly, where there's more resources and a little more controlled environment, then that's maybe your ideal situation as well. You know, maximizing the medical therapy and getting everything else on board. But if you are in a situation where you do need to progress to intubating them, you know, get everything ready as much as you can quickly. You know, you got to have suction, pre-oxygenate as much as you can. You can sedate them a bit. You know, probably with what you have available, you're looking at direct laryngoscopy, potentially with a bougie. Does anybody do nasotracheal intubations, blind nasotracheal? There was a couple of guys where I trained that did them all the time, and they'd bring in trauma patients all the time that they had blind nasotracheal intubated, and they were just like old school guys that, I mean, they'd done it forever, and every time I was like, what? I'm like, what in the world? How did you guys do that? But
we used to do it all the time, and then there was a lot of discussion about introduction of, you know, bugs into the airway and whatnot, and then bleeding, of course.
Sure.
But then they invented that stupid CPAP.
Yeah. Yeah. So.
You did say old school.
Yeah. So you want to look at what you're most comfortable with, and and go to those things if you get in that situation where you need to do that. And then obviously fiber optic nasotracheal is kind of that's what we're going to try and do, because of the fact that the reason that these people are so difficult to intubate is because their tongue is so swollen, because you can't visualize that airway, right? And so by going nasotracheal, and especially if you've got a fiber optic view, that kind of maximizes your best option and best chance of being able to do it. Okay, so then with a progression to surgical airway, let me see if I can. So this is the can intubate, can't ventilate situation, kind of last ditch if you have to do it. There's a couple of different options. You've got the surgical, the needle, and then the quick trach, which I think everybody carries, right?
We don't have a quick trach.
We don't got a quick trach?
Nampa, do you guys have?
We have quick trachs.
Do you?
You guys have quick trachs? What do you guys have?
Scalpel and a needle if we need it.
Okay, scalp. Okay, I don't know why I thought.
And a hook. Let's go.
Yeah. So talking about the anatomy a little bit, and you can kind of, I'm sure everybody's done it multiple times on yourself. You're like, well, is that it? This, that. So anyway, you've got your thyroid cartilage, and then if you come up from the bottom, if you go from your sternal notch and then just kind of follow things up, when you get to that top ring, that cartilaginous ring, that's your cricoid cartilage. So there's just a little recess, just a little space, indentation between your thyroid cartilage and your cricoid cartilage, and that's where your cricothyroid membrane is. Easier to find on some people than others. Positioning is helpful too. If you can kind of get that as anterior as possible, if you have to position somebody to where you can kind of identify it.
No, that new kit's not a quick trach, is it?
No.
It's just a...
Just that it would,
Okay.
It's just a kit that can go open or needle. Okay. So we'll talk about the different options: your open surgical, your needle, and the quick trach. So this open process, and this is just copied from the TVMSS protocols. So again, positioning, hyperextending the patient's neck unless the cervical spine injury is suspected. Bring the larynx and cricothyroid membrane to an extreme anterior position. Locate the cricothyroid membrane between the cricoid and the thyroid cartilage. Palpate that depression in the midline. Caudal to the prominence of the thyroid cartilage. So that Adam's apple sort of structure, which is going to be more prominent on guys, is that it's got to be caudal to that, just down below there. So, and then if you can, you want to be as aseptic as possible. Prep it if you can with time, and then if you have to do this open trach, using a scalpel, you're going to make a little vertical skin incision first, right at the midline, and I'm not gonna. If you've ever seen this, I'm not gonna lie to you. It's a bloody mess. It's like it's. And so, but the other thing too is you don't want to go too big on things, but you don't want to go too small. If you go too small and then you're fiddling around, you can't get things in there. That's a problem for you. So first of all, you make that vertical midline incision, and then you identify the cricothyroid membrane, and then you can go in with a horizontal. Here, we'll go ahead. Horizontal incision through the membrane. Again, you don't want to extend it too far because there are some vascular structures as you kind of move out. But at the same time, you got to try and make it big enough that you're going to be able to get a tube in. If you have a hook, great. Oftentimes what they recommend is that back end of the scalpel to kind of clear it out. A finger does the job too if there's not too many cartilage structures that are going to cut your finger. And then trying to get, and I like this part, gently pass an appropriately sized endotracheal tube. I've never seen it gently passed. But if you can gently do it, gently do it. So at that point, there's usually so much adrenaline, and it's going to take a little effort. But obviously, you don't want to push. The whole idea is you don't want to, push through and cause other damage, or, some of the things that can happen as a mistake, and you guys will notice this, is if, like, especially in bigger folks, you can actually push it into the anterior mediastinal structures and not get it far enough back into the trachea. If that's the case, you're going to get a bunch of sub-Q air, and you're not going to be able to ventilate and stuff, and so you know that you've got a failure there. But if you can get it in, and then like say like a 6, if you have a 4 Shiley or something, I don't know what, if you've got a trach tube, that's great. You can use an endotracheal tube like a 6.0, just endotracheal tube. You only want to go in probably about 2.5, not too far, because you're already down there and you can push it too far, and then cuff it if you can and secure it. And then lots of gauze and pressure to get that bleeding under control. Okay, so talking about a needle cricothyrotomy, these are nice in the fact that it doesn't involve opening everything else, but they're very temporary. If you're talking kids, because technically cricothyrotomies are contraindicated in kids under about 10 to 12. So, needle crics are going to be your better option there. But they are very temporary, but another good option. Again, the anatomy is the same, the positioning is the same, you're locating the same area, use an antiseptic technique, and then, you're going to use a larger gauge needle with a syringe, like with an angiocath syringe attached. You want to go caudally. Actually, initially, what you're going to do is kind of go almost perpendicular. Make sure you can go in, aspirate air, and then kind of move to that 45-degree angle. And if you do it with like a 3 mil syringe, what you can do is then aspirate the air, take that off, pull out your stopper, put that back on, and then get like the top of a 7.0 endotracheal tube and put that on to kind of be able to attach to oxygen. Is that how you guys usually try to, if you were to have to do that, or how do you have that your kit set up, do you know?
I don't think that we have a kit, we just start pulling off spare parts.
Okay.
And usually is it a 3.0 tube that fits the back of the catheter? I think that's right.
A 3.0 tube will fit the back, yeah. And actually, I think it might be here. So, alternatively, so if you can go attach bag valve mask, a hub and needle by whatever means available. There you go, whatever means available. 15 millimeter adapter from 3 or 3.5 ET tube will work. You could also do, and this is what I've seen before, was the 3 cc syringe with like a 7, top of that 7 tube. It kind of works into there. So again, advanced, bevel down, minor bleeding is normal. Well, with the needle, at least you're not having as much bleeding.
Well, it is a child.
Yeah. Yeah, there you go. And then you can secure, and so usually once you got that, what you're looking at is that gen insufflation. So, that 100% oxygen, and, for one second, and then off for 4 seconds, trying to kind of oxygenate them that way. Very temporary. Obviously, letting your receiving facility know what you've got coming in so they can get resources available. So that's the needle option. And then there's this quick trach option. And this is one where the patient's supine. You're going to kind of hyperextend the neck and localize the cricothyroid membrane again. Yeah, you can put your thumb and your forefinger, or thumb and middle finger, to kind of stabilize those areas, and then clean it with the betadine. The thing that's kind of nice about this thing, and I don't know if anybody's ever used one. I've never used one, but I've seen them. They're kind of nice because it's all in one action. So it avoids trying to cut and then make sure you're far enough open, and your finger and everything else that can kind of happen in an open trach.
We put them in a wet lab on goats. I was shocked, so I don't know if it was a function of how thick the skin of the the sheath and the goat's work.
Uh-huh.
But it was surprisingly hard to push it through. Like, it
Was it?
took a lot of force.
Yeah. I'm sure that they're probably tougher skinned, to tell you the truth, so it's probably going to be easier. Like someone that's been dead for a while, a cadaver, usually goes in relatively easy, but those aren't the people that you're going to be doing these on for the most part. So you can hold at the 90-degree angle, kind of go straight, and then basically puncture down. Actually, I think I can find a video. We'll look at a video real quick. So you still aspirate air, and then so you got to take into consideration if they have a real thick neck, you may actually have to go a little bit further. And then you change that 60-degree angle and kind of go down, remove your stopper. And then the other thing that's nice is then you've got like everything there to where, you know, your tube's in, and you can just secure that and ventilate it. So in fact, let me see if I can find, escape out of that, and I'll find a video real quick here. Do I just have?
Down there at the bottom, there's an E.
Oh, there we go. Yeah, is that what that is?
Sorry, mine.
No, that's perfect. They'll let us get into YouTube here, right?
On good days, they do.
Let me see. I think I saw this one. Okay. This is Czech military, you know, so you know these guys are. Do we have any sound, you think? Or?
Sure we do. Will I get it by the time the video's done? Probably not. Okay.
I don't know if there's really any good sound to it. I think some. And it's really short too, so. Yeah, it's okay.
We can make up dialogue as they go.
Yeah. So this makes it look pretty easy here, you know, because you're just there, aspirate air,
Yes, and permanent pressure.
add, push it down, and I mean that makes it look pretty simple and easy. I mean, I'm sure it's.
Yeah.
You should get some of those, Rob. Those look really easy.
Yeah.
Is that other? Should pull that other case. Okay. Okay, cool. Any other questions or thoughts before we proceed on? What am I doing wrong? Right. Yeah. I mean, obviously, you're going to want to. There's not going to be a lot of instances where you, or even us, you know, are going to have to proceed to a surgical airway. But there are those, you know, and you know, just kind of, you think about the ones. Think about the person that's, you know, in imminent danger. Obviously, the person that goes into arrest, things like that. You know, I mean, my thought is if you're not going to make anything too worse on someone that's already, you know, dying or has already, you know, died. So anything you can do to try and help that within reason, you know. So. Okay, so this was an 8-year-old female. How long ago was this?
I was going to let Rob do pre-hospital.
Oh, Rob? Okay,
This
yeah,
was
sure.
in 08. I guess the takeaway from this one is, even though this is an angioedema lecture, the takeaway is that's what this looked like, and it turned out it wasn't. But little girl, 8-year-old, comes to the neighbor's house, says, "I can't breathe," and she's blown up like a tick. Calls EMS. By the time they get there, she's lethargic, if responsive at all, and swollen from head to toe. I guess the key would be that she didn't have urticaria, and then it feels different when you assess it. But and the tunnel vision part of it, which everything seemed to add up, the neighbor said that it appeared that she'd been stung by a bee. I think what we have documented here was that she was 60 pounds, so between 25 and 30 kilos. Is this just this time?
Yeah, it's just having.
So she's supine on the floor. She's very swollen, slightly cyanotic, atraumatic.
Sorry,
That's
it
all
is
right.
early this morning.
Well, and our spell check screws things up too, so I'm glad it wasn't worse.
Can't blame spell check for that, because I don't think that's.
No, this is me trying desperately to get done.
Eyes are swollen shut. She's swollen everywhere. It looked like her jaw was locked.
Okay, so
Go ahead. Go ahead.
you're good?
Oh. And it didn't appear that she had any trauma.
See,
Nope.
I'm still traumatic.
No, you're good. At least you were consistent. No crepitus, you've got to, I guess that depends on what you're trying to identify. No bony crepitus. She had apical breath sounds, but they were diminished in the bases, and what I have is that she's got apical wheezes bilaterally. So, no hives, pink and warm, looking poopy. She gets 0.3 milligrams of epi sub-Q. Keep in mind this was an 08.
Yeah, guys, really good.
Benadryl, 50 milligrams, 18 gauge. This was a cluster. I mean, it was a scary call because she was 8 years old, and I don't know that this will talk about it, but I'll talk about it here. At some point, as fire and EMS arrived, Dad shows up and comes in the house, and then he grabs a TV and is looking for a place to throw it. So everybody's trying to dogpile him and take care of her. So you can see what they did here. They're going down the allergic reaction protocol, which seems appropriate. And then I guess we'll slip into the hospital side of things here in a second. But from dispatch to arrival on scene by our guys was 6 minutes, and I apologize, I don't have Nampa's numbers.
It was a little bit before that, because I happened to be there.
Did you? Okay,
Yeah.
good.
And all was very consistent with what you described. It was after you left that the friend came along and introduced the idea of her crashing into a parked car.
Good, because I could not
Okay.
figure out where, that's why the bike crash is up there, because all of a sudden we went from,
And somehow that
Allergic reaction
information
to
ended
a
up at the
bite.
hospital, but we didn't have it to start with, is that
So it
right?
was after Canyon left, before fire left, that we.
Good, and I guess that's the important thing about how we work together is, after we're standing around cleaning up, start asking questions and be a detective, because sometimes that stuff's pretty darn important. So 6 minutes from dispatch to scene, on scene for 13 minutes, and I don't know how much of those minutes were taken up battling Dad, but I'm sure that a lot got done in the back of the truck before they just left. And then transport was 9 minutes for 2.3 miles. Okay?
so we got her, and again, thank you for that, because I could not figure out how we went from all the allergic reactions to, now we're getting in report that this could have been a bike crash. And that's all we got, was it could have been. So again, with time that has gone through, now that we've got crepitus to the head, airway, neck with edema, chest has got some sub-Q emphysema that they're noting.
Now, keeping in mind the difference between crepitus sub-Q air versus bony crepitus.
Yes.
That's a big key. It's not well defined there, but that's what it is.
And rightfully so, like I said, and you guys all know with airway stuff, it takes all of about 3 minutes before things change, and so that's why we've talked constantly about reassessing. So again, and now we're trying to decide, are we at allergic reaction or are we at a trauma? What way are we going? And so we're trying to do both, and so now we're going to bike crash. So now you have to do a head to toe, all the things that are in there. Abdomen soft, non-tender, pelvis is stable. No trauma noted when we turned her over, but we're still having to bag valve mask to get her breathing because she can't do that on her own. And then the doc comes in and evaluates her and can't hear lung sounds on the left. is what, and again, I can't pull up all the docs. This is so old that it's our old documentation. It's actually in storage, so there might be a few things that are a little different, so I apologize if they are. And what he documents RSI, but he used just the Versed and fentanyl, so it wasn't a true paralytic that he did, but he used the words RSI. So,
Do you got a doc's name on there?
It's Dr. Black. Meds.
Oh, yeah.
So anyway, we did a needle decompression on this kid, positive. You know, when I talked to the nurses, the two nurses, they're both still here. They heard the classic swish, and you went, oh. And all of a sudden, RT is sitting down saying, yeah, it's a little bit easier to bag. You're kind of going, oh, okay. Finally get a chest tube because we've RSI'd her and we're wanting to check placement. And radiologist comes back and says, hey, you might want to do it on the other side too. And so by the time we were sitting down, she had bilateral chest tubes, all basically from double tension pneumos is what we ended up doing and flying her out of here. So although we were headed down the angioedema, it's kind of interesting that, you know, you can't keep on that same idea. And thank goodness for, like I said, I could never figure out where all of a sudden which crystal ball came up with the idea that this was a bike accident, because everything we were hearing was, you know, everything you looked at pre-hospital was neighbors saying, I think she got stung by a bee. Well, the neighbor wasn't there because curl came up and dinged on her bib, said, I can't breathe.
And I think that's one thing that's so hard, particularly with kids, particularly with like bystanders and stuff, and you guys are dealing with this constantly, is that any history you can obtain is helpful, but it also can be misleading, you know. So trying to consider everything, you know, that's told to you is important, taking everything serious, but also trying to put it all together and filter through all that is another key as well. And keeping your differential broad, especially if at any point you're going down a pathway and you're thinking, boy, this is what it really seems like, and it's so easy to get tunnel visioned, especially in one of these cases that are really stressful and really, you know, where you've got someone that's really decompensating or very decompensated to begin with, trying to decide and keep a differential out. I mean, obviously, someone like this, she's got classic signs. She's got not all the signs, but she's got swelling, she's got all this kind of through that whole region, which looking back on it, you think, oh, well, this is all emphysema. This is all, you know, she's got air going all the way up through her mediastinum, you know, through her chest, up into her face and head and everything else, you know, and that's why she's swollen. But
I remember talking with the paramedic that was on this, and he said, but when they walk in, it's the same thing we talked about. He said, they're going down the allergic reaction path because everybody's saying, oh, we think it was a bee sting, it was this, everything fit perfectly. And it wasn't until they were either at the hospital or almost to the hospital, they realized that swelling was sub-Q emphysema, and then it changed everything, because I think at that point they still hadn't heard about the bike wreck. And he said that because you were with Ben that day, and I think he was already here with the crew, the ambulance crew, before they ever heard any of that. So,
yeah, it's hard. I mean,
Well, I have to say, you know, from the receiving point, we are totally grateful when you guys sit back and tell us, or, you know, no one's thinking about their home medicines, and all of a sudden you guys come in with this list of medicines, and we're going, really? They're on that? Well, that sure changes the story. And although we have extra resources, I have to tell you, the first case that he talked about, I'm not quite sure how in the world we actually had all those resources in, because it was after hours.
it was his time.
Yeah. Well, and the one that we had here was after hours, so we pulled the anesthesiologist. He happened to be working out at the rec center next door. They had already gone home. You know, cases were done by 3 in the afternoon, and this was 5 o'clock-ish. So they were already gone. And just so happened to have the surgeon in here. You know, surgeons don't live in our department. Sometimes they're harder than others to get into our department, so it was just nice to have it. And then we played the where is, because you don't pull all that kind of stuff out all the time. So I don't want to fool you into thinking that we have all these resources either, because I had a hard time finding things that on that case of where this was. The bronchoscope does not live in our department. It's an OR. Well, OR's not around. So we played a little bit of Where's Waldo and tried to figure out where they were going. But I can't tell you again how important it is for you guys to kind of at least lead us on, because, you know, we could actually go into a whole different place. So we really truly appreciate the second and the third call that says, hey, wait a minute, I'm talking to this is what we know. And
Yeah.
it really is helpful for us to find that out, and we appreciate you guys going the extra mile to go get that done, because it really does help us out tons.
Yeah, and certainly don't ever, I mean, even if you think, maybe it's not applicable or not involved, I mean, what's the worst that you're going to do is like tell us something that, doesn't really matter or whatever, but there may be something super, super important, so don't ever hesitate. And on the other side, if you guys ever want to know, and I try to speak for myself, and I hope for the most part, all the docs are this way, and I think they should be. If you're just curious, you want to know like what happened or what's going on with the case, we like to receive those calls. Give us a call, and we'll happily update you on things and things like that as well. So.
Do we know the outcome of this little girl? I know she was life-flighted, but.
Actually, yeah, she came back. Dad brought us chocolate and apologized for whoever he was after here, but by then we knew.
You didn't give me that chocolate, did you? No, no.
So whoever got punched in the face.
Yeah, right. Hey, tell that guy I'm sorry, would you?
Airway bringing chocolate.
There's your
that's what
apology.
we did. And then they moved out of state about a year or so afterwards. But yeah, little girl was up and walking, and it was quite a sight, actually. So, and like I said, we contribute that to you guys, because we would have probably continued down that same pathway of an angioedema, and why isn't this working? And at least we'll get her intubated, and then about the time that we intubated her, we would have sawn both the chests. So.
And angioedema doesn't have a huge differential either, So I mean, it was perfectly reasonable to kind of pursue that, especially based on the history that was received. So.
Any questions? Any comments? Anything?
Very good.
Well, thanks again for coming out. We appreciate y'all. We'll see you third week in May. And like I said, if you guys have a great